In this presentation, the application of the basic forearm circular cast will be demonstrated. In general, the basic forearm circular cast is applied after reducing a distal radius fracture in order to maintain the reduction. The basic forearm circular cast is indicated for collis fractures, distal ulna fractures, and in children, fractures of the distal radius and ulna. This X-ray of a collis fracture shows the dorsal displacement and dorsal tilt. Another X-ray of the same patient shows the radial displacement and impaction. With reduction, these displacements will be corrected. The reduction will be maintained with the correct application and three-point molding of the cast. To apply the basic forearm circular cast, the following materials are needed: a stockinette or tubular gauze bandage, cotton wool, 100 millimeters wide, will be used as undercast padding. For children, a width of 75 millimeters is sufficient. Scissors. Plaster of Paris bandage, which is available in rolls of varying widths. And water, or another wetting agent. The water should be tepid or lukewarm with an ideal temperature of between 22 and 25 degrees Celsius. It should be noted that colder water or a bandage that is wetter will allow for an increased working time, while warmer water or a bandage that is drier reduces the working time. The patient should be seated next to a table or trolley, with the elbow at the edge of the table to allow full access to the forearm and wrist. The dorsal side should face upwards, with the wrist in slight palmar flexion. This flexion will prevent the cast from sliding off when swelling subsides. The distal border is located no lower than the distal palmar crease, so that the patient is still able to flex the MP joints to 90 degrees. The proximal border lies about 2 fingers distal to the crease of the elbow, so that the patient may flex the elbow. The forearm cast should allow the patient use of the thumb, so the thumb should remain open. To begin, a stockinette is applied and cut slightly longer than the final cast will be. A small opening is cut for the thumb. A slit is cut in the cotton wool to go through the first web space and allow the patient to continue to pinch the thumb and fingers. The cotton wool is gently wound around the forearm. For a tight-fitting cast, a single layer of padding with an overlap of 1 centimeter may be used. However, this short overlap is not generally advisable. Rather, an overlap of 50% is recommended and is shown here. The 50% overlap creates a double layer of padding. Proximally, the cotton wool extends beyond the planned length of the cast, so that when the end of the stockinette is folded down, the end of the cast will be padded. The plaster bandage is dipped into the water. The end remains free, with the bandage held at an angle of 45 degrees. The bandage is held in the water until any bubbling subsides. The bandage is removed from the water. The excess water is removed by gently squeezing the ends on both sides. The application of the bandage should not begin in the first web space. Rather, it should start at the wrist, with 1 complete turn. The bandage is then passed through the web space where it's gathered together. Then it goes across the palm of the hand using the full width to the base of the thumb and around the wrist. This procedure is repeated. The bandage is now wrapped around the forearm in the proximal direction, in the same manner as the cotton wool, giving an overlap of 50%. At the proximal end, a slight amount of cotton wool and the end of the stockinette should remain uncovered. The bandage is once again wrapped around the forearm, this time in the distal direction. It should be noted that although 4 layers of plaster bandage have now been applied, the shininess of the material indicates that the cast is still too soft to mold to the desired shape. While waiting for the plaster to set, the ends of the stockinette may be folded over the ends of the cast. The stockinette around the thumb is cut and folded over the plaster. Although it can be seen that the plaster is now becoming dull, indicating that it has begun to set, it's still too soft to mold. At this time, a second plaster bandage should be applied in the same manner as the first, beginning where the first bandage ended, to ensure a uniform thickness of the cast. The second plaster bandage secures the loose ends of the stockinette. Uninterrupted application of the plaster ensures the integration of the different layers. The result is a strong cast that prevents an onion skin effect between the layers of plaster of Paris. After the application of the second bandage is complete, the shape of the cast is circular. The reduction will now be secured with a 3-point molding of the cast. However, it should be noted that the plaster will not achieve full strength for 36 hours. The plaster is molded with pressure applied over the dorsum of the distal radius and from below onto the forearm, just proximal to the distal molding. In other words, just proximal to the fracture. The pressure at these 2 points results in the desired oval shape of the cast. The third pressure point is a diffuse area, located slightly proximal to the dorsum of the radius, where the extensor tendons originate. The plaster may be smoothed with a circular motion to achieve a better fit to the forearm, taking into account the oval profile. The palmar plaster is now molded to securely fit the hand. Flexion of both the thumb and elbow are confirmed. The exercises for the patient may now be explained and demonstrated. They include full flexion of the MP joints, full flexion of the PIP joints, and placing the ends of the fingers into the palm of the hand. The forearm cast should not be too wide in the web space, so that the patient can continue to pinch the thumb and fingers together. The application of the forearm cast is now complete.